But
Yes.
be here. You have to wait until the end because your case is so strong. You may have the first prize. So let's
Thank you,
see.
sir.
Let's
Thank
see
you
the
very
other
much, sir.
cases.
जी जी
Okay.
sir. Thank you.
Okay.
Thank you very much, sir. Okay.
Okay. We move on to the next one.
Dr. Ajay.
Ajay, it's your presentation. Ajay, go
Yes,
on.
sir.
Ajay
Uh,
also comes with very nice cases.
Good morning, sir, and all the my presenters. Myself, Ajay. Is my screen visible, sir?
Yes, visible.
Okay.
No, screen is not visible. You are visible. Okay, yeah, screen is now visible. Just make it slideshow.
Yeah. So, good morning to everybody, and thank you, Rajneesh sir, for giving me the opportunity to speak on this forum. Today, my presentation is on Rotacut strategy in calcified left mid bifurcation, and the side topic is the side heading is that we should be ready with our bailout strategy. So my history and presentation, my patient is a 60-year-old male presented to our OPD with chief complaints of exertional angina of class 3 NIHA, despite on guideline-directed medical therapy. He is a smoker and hypertensive control on medications. ECG was normal and echocardiography showed mild concentric LVH with no other lumen or any valvular dysfunction. After considering the current clinical condition, coronary angiogram was done. This is the baseline angiogram of the patient. Right coronary artery was hooked, which showed non-critical lesion. However, when left artery was hooked, we can clearly see there is deep calcification present at the ostium of LAD, LCX, and distal left main. There was significant lesion in the ostium of the LCX and proximal LAD. In aleocranial view, you can clearly see distal left main was 60-70% stenosis, and there was deep calcification, which is eccentric in such situation. The syntax score was 17, and after discussion with the patient's attendant, we went for an diagnostic. We went for an intervention. Planning for a provisional. My plan was to go for a provisional intervention itself. So pre-procedure, we did an IVUS evaluation, which showed from left main to LED, it showed diffuse plaque with calcification of more than 180 degrees. We can clearly see in the run there was diffuse plaque present, calcification in left main. L6 ostial run was also done, which also showed eccentric calcification and significant disease in ostial of the left circumflex. Ostial AD lesion, and there was more than 50% plaque burden. Following that, the plan of intervention was decided that we be going for upfront bifurcation using a rotacut strategy and decay crush stenting. So in this situation, when we did an IVUS run in our patient, we can clearly see there was a true bifurcation lesion. Ostial LCX was also calcified, significant plaque. Distal left main had plaque, and along with that, so following that, these are the intervention. We started with a 2.0 millimeter rota ablation. This is a 8 French guide. We passed the rota wire and we started a rota ablation of left main to LED because there was significant plaque. Following that, I took a cutting balloon of 3.5 millimeter Wolverine, dilated ostial left main, the stent. After deploying the stent in the LCX, step crush, it was done using a 3.5 millimeter balloon. Following that, an ostial left main stenting was done using a 4.38, 4.0 into 38 millimeter stent, which was deployed. And post that, a port was done with a 4.5 millimeter balloon. Kissing was done with a left main and LCX using a 3.5 and 3 millimeter balloon subsequently. And a final port with 4.5 millimeter balloon was done for the left main.
Can you show the final video because your videos were still not running?
So is it visible now?
Yeah. Yes.
So this is the pot which was done using a 4.5 millimeter balloon. Following that, a kissing was done using 3.5 and 3 in LED and LCX, and the final pot was done in Austral for the left main. These are the IVUS run. Post procedure IVUS run, the Austral LED MLA was 13.20, which was acceptable. Left main was 16.32. There was properly a post stent from left main to LED, and Austral LCX IVUS was also done, which showed MLA of 10.12. So uh, these are the final angiographic shot of my patient, which showed there was no major dissection, and the bifurcation was good. There was no canine shift and proper position of a stent. This is the cranial view, where we can see that the left main was, or still left main was properly covered. There is no under expansion. So the take-home message from this case is that DK crush technique is better than the rest of bifurcation strategies when considering true bifurcation lesions. However, not all the cases are same and go as planned. It is important to understand that we should have a bailout strategy with which we are comfortable in case of complications. As in my case, there was left mid dilatation. post cutting balloon dilatation due to aggressive dilatation. So I was most comfortable with step crush or mini crush. I subsequently switched for the simplest and more efficient stenting, saving the patient with excellent angiographic and IVUS results. Thank you.
Thank you, Ajay. Again, a nice case as it is expected out of you. You always do very prolific interventions. I have seen that with your previous cases also. Only small change which I would have done, I think you put a stent in the circumflex and then placed one balloon across left main to LAD. After stenting the circ ostium, you crush your stent of the circumflex with the balloon. So now
NC balloon, yes.
in mini crush, you could have just placed another stent, 4 into 38, whatever, from
Yeah.
left main to LED simultaneously and crushed with that. So obviously that requires your stent placement at circumflex ostium, then take your balloon little bit back, go more pressures, and then take a wire and balloon out, and while your stent is there, and then place a stent. That removes one step because your dissection was there. If it
So
is,
my
if it is,
original plan was this only for
uh,
mini crash because often in usually in an LED D1 when I do bifurcation I crush the stent using the stent, that is the true mini crush. I followed a step crush here because if there was significant calcification and I always had doubts because my rota valve, I took the largest rota valve which was available. Despite that, I was not sure had it done the debulking because the artery was very big. And because of unavailability of IVL due to financial concern in this patient, so my thoughts were that it might be possible that I might get stuck in the calcium or some calcium spicule. It is better to crush it so that in future, for while taking another stent, there will be no push and pull, or there might be no push and pull with the studs which will be hanging from LCX to LED in case there is improper or any kind of improper crush. Uh, that's why. So I thought it better to do it with an NC balloon so that I will immediately take another stint. That will be easy for me and it will be more sure for me that I will not create any complication because once one case I was trying this. So what happened? I took another stent also, deployed the first stent. When I was pulling back the original stent, that stent got lost. The balloon came out. The stent was lost in the distal part. Then again, the stent was deployed at the distal end, and again another stent was taken. So from that, I took a lesson that it is better to take a new balloon, crush it, step crush, and then that in case. And your point is absolutely valid when there is
no,
left
no,
mid
it's fine. It's
dissection.
fine. I'm not saying it. So this is also fine. I was saying if the blood flow was getting hampered because of
Mm.
the dissection, then to save time, this is one.
Yes, yes.
So what you did was absolutely fine. The only thing is then you have to have a good balloon
Yeah.
size, crush the stent at the circostium. But otherwise, very well done. And I like your cases, the way you do it. And the end, the result was very good.
Sir, my question is, I have few doubts in this intervention that in such cases where we have because Austin LED was of 3.25, I took a bulk of 2, considering that I will be doing it for the LED, the 2 millimeter bulb will work for the LED also. The what can be done for such large left main with distal calcification, which is eccentric.
Now what these are two different mechanisms. So 2 millimeter burr will only decalcify inside from inside the if there are protrusions, calcium nodules or spurs inside the lumen. So that will only burr the inside of the artery. It's not going to go with the deeper calcium or at a 3.5 millimeter vessel.
Yes.
So for that we have to have a IVL or nowadays we have a better debulking. Now, the more circumferential debulking happens with the orbital as compared to rota. It revolves in an orbit. So from rota is just creating a central thing. If it is a non-crossable lesion, if calcium is protruding deep inside the lumen, so that is going to, decalcify it from inside. It's not a concentric decalcification. So orbital has a better concentric decalcification or it is IVL, which is going towards a deeper calcium. So I think that's okay. So it depends, availability of a decalcified gadget at that point of time.
So,
But
so, so we have an orbital which can go up till 3.5 millimeters, sir.
yes, yes. So
Okay.
the orbit of the orbital
And
atherectomy increases based on the vessel size.
Okay.
And the speed, speed and so the orbit, if it is 2.5, it should not be used less than a 2.5 vessel. 2.5 to 3.5, it will increase the space of orbit. It revolves up and down.
Yeah.
So based on the space available, it will create its own orbit.
Okay.
Okay, good case, Ajay. Thank
Thank
you.
you.